which is something which brings all of us here together as well. We all kind of come from different disciplinary backgrounds. And Charlotte also is research director of a DFID RPC, which is a big consortium to do research on the structural drivers of HIV called STRUCT. Charlotte has published over 100 articles, has worked closely with UNAIDS, the World Health Organization. I'm sure many of you will come across her work in one context or another. I fondly remember a nice meeting we had together in The Hague, where we were part of a research project that was looking at the links between HIV, AIDS, and security, and I was there because of my background in international relations, and Charlotte was there giving an excellent presentation on the role of rape in conflict settings and what that means for HIV transmission. So Charlotte, it's a real pleasure to have you with us today. I think you're going to speak for about 40-45 minutes, and then we'll take some questions after that. And you'll be speaking on intimate partner violence and definite risk factors for poor health globally. Charlotte.
Hi. So thanks, it's a real pleasure to be here, and it's really, it's a nice small group, so I hope we can have some interesting discussions. Once I've gone through the things that I thought might be interested to hear. I thought I would give you a bit of an overview, if I can get the slides to of a few different areas that we've been working on. First, just to kind of share some of the data that ourselves and colleagues around the world have been collecting about what do we know about the levels of violence that are happening, and particularly intimate partner violence globally. Then talk about it and the sort of work where ourselves and working with organisations like WHO are really starting to think about violence as a neglected risk factor for poor health, and maybe at the end we can revisit actually why it isn't really seen much, or commonly isn't seen as a health issue. And particularly I'll talk a little bit about some of the work we've been doing looking at the links with HIV, because that's kind of my background, but also a little bit with suicidality. And then lastly talk about one example of some intervention research that we've been doing, which is really trying to help address the kind of pressing policy question about, well, it's a big issue, but what do we do about it? So we're also trying to do intervention strategies, go, actually, can we prevent or can we impact on the levels of violence that are happening in different settings? So the term intimate partner violence, some people will think about it as domestic violence. When we use the word intimate partner violence, what we're really thinking about is any actual or threatened physical or sexual violence or psychological or emotional abuse directed towards a partner, an ex-partner, a current or former boyfriend or girlfriend, or a dating partner. So it's violence within an intimate relationship. It's kind of what it says on the tin. And the kind of things that we might be talking about if we're thinking about physical violence might range from things like slaps and kicks through to more severe forms of physical violence like strangulation, beatings, use of weapons against somebody. We're thinking about sexual violence. There's a broad scope, often in the kind of research that is being conducted in low and middle income countries. We're focusing on issues around forced or forced sex, and that might be either through physical force or it might be through threats or intimidation. There are also a range of psychological forms of abuse that increasingly people are starting to quantify, and that might be things like forced isolation, verbal aggression, humiliation, stalking, withholding money, controlling a person's access to healthcare or employment, these sorts of things. That last one is one that when you speak to women who are experiencing violence, they go, that's the really important thing. But actually, as researchers, we really struggle with how to quantify that. And a lot of the work that myself and my colleagues do is often quite quantitative, because it's trying to give a sense of the scope of the issue as well as the severity of the issue. And so actually, when I'm going to show you some figures on the levels of violence, and actually what I'm going to be showing you is data from mainly looking at physical and sexual violence, because that's sort of where the field is at this point in terms of feeling more comfortable about quantifying it. And the way that we get that data is really by asking women in private, or men in private, very direct, behaviourally explicit questions about their experiences of specific acts of violence. Early on in the field, we used to ask, have you experienced domestic violence? Have you been raped? But those terms are just so subjective that really you don't know if a woman says yes or no what that really means. So kind of as we've got experience now, the sort of gold standard is that we use these very behaviourally explicit questions. And this field is fairly new, so this plot just shows kind of the number of publications over the last 10 years of people publishing just on the prevalence of violence. So it's something that actually kind of in the 90s, late 90s, really was not really there on the kind of research agenda. But now it's really, in that sort of post-Beijing and some of the big international meetings, is really starting to get a lot more research attention. One of the first big studies that I was involved in was working with WHO to do a large 10-country study to collect data on the extent of violence around the world. So that was really following Beijing, where one of the big kind of recommendations was we need better, kind of reliable, comparable data about the extent of violence and its different forms of impact. And so I'm not going to go into a lot of detail, but just to give you a snapshot of the findings. I mean, what we did is work with partners in 10 different countries, and so the countries around the world are coloured here. In some settings we did surveys, sort of large household surveys in 2 contrasting settings. And in other settings we only worked in one site, and that was often just to do with the sort of logistics and country and what the partners felt comfortable with and the sort of resources that we could mobilise to actually fund the surveys. And so for each of these studies what we were doing is working with local academic partners, training up a team of researchers who would then randomly select women from households and ask them a lot of questions about their lives, about their health, but also ask them very behaviourally explicit questions about their experiences of violence. And because we were working on this issue that's quite challenging, as part of that we also had to make sure that our interviewers were trained, so if somebody got upset, if they requested help, we could handle that. And we could also refer women and handle cases, emergencies that might arise during the fieldwork process. In practice, what happened when we created that space and we had good interviewers, if anything, respondents wanted to tell their whole story. So actually we didn't have much of a problem with women not wanting to disclose. If anything, it was that you create that space and somebody's talking to them about something really important. And if anything, you have to budget for 2 hours per interview versus 1 because the woman wants to say her story. So when we were doing this work, people were like, oh, it's too scary, you're not going to do it, women are not going to want to talk. But actually that wasn't our experience at all. If you do it well and carefully, if anything, this is something that is pressing and is there. And once you start opening and asking, then women will tell you a lot. So this slide shows the findings from that 10-country study. There are a couple of extra countries added on there that are countries that have, subsequent to the sort of first round of the WHO multi-country study, went on to also use the questionnaire and to do similar surveys. And so you can see we've got this sort of range of countries, and just sort of this gives shows the percentage of women who report ever being physically or sexually abused by a partner in their lifetime. So it's an ever exposure measure. And if you just look, for example, above the 40% bar, you'll see that there's a whole range of countries that are reporting more than 40% of violence. So, is this right? Yeah. So, sort of, for example, Bangladesh, Ethiopia, Peru, Tanzania, Thailand, Turkey. So it's not like we've got certain areas of the world where there's a load and then everywhere else there's lower levels. What we're seeing is, in a range of different countries around the world, there are very high levels of violence. And even when we look at some of the countries with a lower prevalence, so for example Japan, you're still talking sort of about 15% of women experiencing violence. So even in our low prevalence areas, it's still a common event. So this study, because it was WHO, was very much focused on low middle income countries, apart from Japan that managed to fundraise themselves through the work. If we look at evidence from the UK, we come up with also that it's a common issue. So this is data from the UK Crime Survey, the British Crime Survey, which suggests that 30% of women and 17% of men have experienced domestic abuse since age 16. Now in that figure there is some acts of psychological abuse, so it's a slightly broader definition. But again, it sort of illustrates the high levels of violence. And 90% of women will experience sexual assault, and 2% of men. And we also see high levels of violence against different populations. So for example, gay men and lesbian women. There's been a couple of different surveys with different samples, but suggest that there might be very high levels of domestic violence and same-sex relationships as well. in terms of thinking about it as a health issue, it's a strange issue because once you start unpicking it, the health impacts are multiple and often profound. So if you think about exposure to partner violence, the kind of direct disease outcomes that we're talking about are impacts on sexual and reproductive health, so things like HIV, syphilis and other STIs, things like induced abortion from unwanted pregnancies. We have the direct consequences of injuries associated with violence. We see a range of poor mental health impacts associated with experiencing violence. We also see maternal health impacts in things like perinatal, infant and child health outcomes. And then we also see impacts on mortality, and that's not only from direct homicide, women or men being murdered by their partners, but also from suicide, where women are committing suicide often after a long history of exposures to violence. And also perinatal and infant deaths, so for example, related to violence whilst a woman is pregnant. What we also see is that exposures to violence is also related to a number of kind of risk factors for poor health, so things like alcohol use, unsafe sex, and tobacco use. So as well as these direct impacts, this exposure to violence can also lead to a chain of other risky health behaviours that can have downstream poor health consequences. And to give you an illustration of this, this is a summary of some analysis that we did with that data from the WHO multi-country study. And what we looked at is looked at the odds of poor health, induced abortion and suicidal thoughts across each of the countries. And I'm just showing a snapshot of the countries here just to give you a flavour of the findings. And to me what we see is these significant associations with these different types of poor health outcome across each of those settings. And for me what was surprising was actually how similar some of these strengths of association are across all of the different sites. So if you're a woman in Japan where violence isn't very common, your risk of having poor health is equal, you sort of experience the same magnitude of health impacts potentially as a woman in somewhere like Ethiopia, where violence is much more common. And where you could be saying, well, it's normative, it's a common thing, maybe it's less severe, but actually this sort of data suggests that actually we're seeing fairly similar effect sizes. That this has an impact whether you're a woman in a setting where it's not common or a setting where it's extremely common. To give you a little bit more insights about the data, this is showing our data again from the WHO multi-country study about suicidality. So we asked women about whether they'd ever thought about committing suicide in their lifetime, whether they thought about it in the past 4 weeks, and whether they'd ever attempted to commit suicide. And this is showing the data across all of our sites. And I don't, you can't read the font, it's so small. But again, you see across this that there's, in a number of different settings around the world, you've got a high percentage of women who have contemplated committing suicide at some point in their life. A lower percentage, but pretty shocking levels in many places of women saying that they've thought about it in the past 4 weeks. And in some settings in particular, quite high levels of reported suicide attempts. So this is kind of Brazil here, this is Peru, this is Thailand, for example. So then when we try and tease out what is exposure to violence, does that increase a woman's risk of contemplating or committing suicide? What we see is actually very strong associations. And what we see is both associations with childhood exposures to violence, as well as independently relationships to adult experiences of violence. So that's both intimate partner violence and other forms of physical violence. And what was shocking linked to this is I showed you that figure about the percentage of women who had contemplated suicide in the past 4 weeks. And actually when we looked at the data, 20% of those women who contemplated suicide had also visited a health provider in the past 4 weeks. But the odds on would be that actually nobody asked her about her probably assessed how she was doing, let alone what might be the risk, what might be the reason why she might be presenting depressed or seeking health services, for example. And to me, that's the sort of challenge when we're thinking about starting to frame violence as a health risk factor, is then what do we do about it, and how might the health sector potentially be involved in helping to identify and support women, as well as helping to think through what are the kind of preventive interventions that might be effective to reduce the prevalence and incidence of violence in the future. I'll just move on to the other area that we've been doing a lot of work on, which is on violence and its links with HIV. And then within the HIV world, this has been quite a hot topic, because groups like UNAIDS made violence against women as one of their core pillars of prevention. But then there was this sort of underlying question of, well, is violence a risk factor? Why might violence be a risk factor for HIV? And so to try and sort of answer that question a little bit, we did a big literature review, systematic review of the epidemiological literature, and sort of looked at, well, what do we see from current evidence? So we found lots of papers. We saw a few perspectives, so forward-looking studies that are actually tracking women over time, a load of cross-sectional data, and a few case control studies. When we look at the strongest evidence comes from prospective studies. So where we're looking at, does exposure to violence, is that associated with a new HIV infection? And these studies are really hard to conduct, so there aren't many of them in the world. But when we look at them, there are 3 that do find a relationship. Well, there are only 3 and they all find a relationship. So one of them was in South Africa. And this showed that women who'd experienced physical sexual violence were more likely to become HIV infected. So it showed a kind of exposure and the incidence infection relationship. Similarly, there's a study in India that looked at sexual violence by partners, and they found that was associated with new STI infection. And lastly, there was a study in Uganda and Rakhine that looked at the relationship between sexual partner violence, and there, again, they found a relationship with incident HIV infection. So there's starting to be this evidence that points to, yes, it actually is a direct risk factor for HIV. When we start looking at the cross-sectional data, so that's the data from household surveys, where you don't know, what comes first, the infection or the exposure to violence, the data becomes much more unclear, and the analyses become more unclear. And to just illustrate this, this is all data from analysis of a data set from India. It's the same data set, okay? Different people have taken it. And this bar is the kind of odds ratio of 1, where there's no difference if you've experienced violence or not. These plots represent the findings from all of the different studies, right? And this bit are the confidence intervals. And you can see they're all over the house, right? It's a complete mess. So if I was a policymaker and I'm going, well, is violence an important risk factor? And academics are meant to be able to help answer these sorts of technical questions. And actually, we are doing a very good job, And to me, it's really frustrating that this is the state of affairs. And when you actually sort of unpack what's going on here, you've got different sort of outcomes. So some, looking at biological data versus self-report, we tend to see more association when we're looking at reported infection versus actual biological infection. But there's also issues just to do with sort of some of the quality of the analyses, so whether things like the clustering of the data has been taken account in the analysis. There's some things that shouldn't be varying between analyses that are, and actually really influence the findings quite a lot. And so, and actually this is the one that we like, this one by Silverman, here, these 2. And this is exposure to both physical and sexual, and this is exposure to physical violence. But in terms of quality of analysis, that's for us seemed to be the best one. But you can see it's a bit of a mess when we start looking at the cross-section. When we try and focus in on what are the studies that do seem to have done a reasonable analysis, and one of the issues is making sure that the comparison group isn't exposed to violence of any sort. This is the kind of meta-analysis, and this is where we're trying to aggregate out what are the findings from different studies find. So when we look at physical violence, there's only a few that we've ended up putting in a meta-analysis, but we find a significant association to the right of this bar for one. When we look at sexual, which is the one that most people think of, that's why somebody gets HIV infected, they're being forced to have sex. We don't see this association. When we look at physical and or sexual, it's nothing really clear comes out. When we look at physical and sexual, it comes out quite clearly. So to me, this is quite interesting because it's slightly counterintuitive. And I'll talk a bit about why we might be seeing this in a minute. I suspect this one reflects that women who are experiencing both physical and sexual violence are experiencing slightly more severe violence. And so it might be that if you're experiencing more severe violence, that increases your risk, and that's might be why it's being picked up in these studies. But it kind of illustrates, you can start off asking a simple question, but actually it's quite hard to actually figure out what the answer might be. The reason why we think we might be seeing that clustering of risk relates to that relationship between physical partner violence and HIV. We think relates to the likelihood that there's a clustering of risk behaviours underlying that. So what we see from behavioural research is evidence that men who are abusive to their partners are also more likely to have concurrent sexual partners, are more likely to have an STI, are more likely to have problematic use of alcohol, and are more likely to have refused a condom. And so kind of underpinning this sort of epidemiological question is actually a whole lot of issues around constructions of masculinity, expectations in relationship, that actually is probably driving both that man's vulnerability to HIV and the likelihood that he is using violence with his partner. You've also got the issue of early exposures to violence that again might be associated with later HIV-related risk behaviour, and also that man's likelihood that he uses violence, or a woman's likelihood that she enters a violent relationship. So that sort of the kind of pathways of causality in the end are probably quite complex and probably relate much to issues around masculinity, relationships, early experiences of abuse, and what that means down the line for vulnerability to violence and HIV. So I'm going to move on to the last bit, which is about can we prevent violence? And I think it's good to talk about interventions, because otherwise you get hit with all these depressing figures about the levels of violence around the world, and oh my god, and it's got so many health impacts. I don't want you to leave completely depressed at the end of today. To talk about some of the intervention studies that we've been doing. And for us in particular, there are groups that have been saying, well, what role might the health sector play? What can we do for an accident emergency setting? What can we do for in family planning? A lot of the work that I've been doing with colleagues at the London School is really saying, can we prevent violence? What's interesting is actually there's a growing body of really interesting, exciting interventions being tried out around the world. Not many have been evaluated, but there's starting to build up some evidence of actually we can impact on violence, and we can potentially shift norms around masculinity, around the acceptability of violence and so on. And the kind of programs that sort of I think have a lot of promise are things like participatory gender training for boys and men. And so the kind of examples you've got is very well-known examples from Brazil, with Program H, that's been replicated in India, it's called Maribatum. There's a men's discussion program that we've been evaluating in Côte d'Ivoire. Men as partners, another widespread program focused on men being implemented in Tanzania and other settings. There's also participatory programs that are focused on sort of young boys and girls in communities, and so things like stepping stones that's being involved in a trial in South Africa, but also used in many, many different settings. There are also more community-focused interventions that have tried to say, let's take a more holistic approach and think about how do we influence both community norms, how do we influence the local structures, so how do we work with the police, how do we work with traditional leaders, how do we work with health providers and the police and all of these to try and create a more supportive response to violence, but also try and shift a whole community through a process of change. And so we've been also just wrapping up an evaluation study of a program called SASA in Kampala in Uganda. There are also broader kind of social media, social change interventions that have used things like soap operas, but embedded messages around gender and the non-acceptability of violence. And kind of examples of that are things like Soul City in South Africa. That's a very slick media program that brings in issues around violence, HIV and gender. And then also you've got the kind of campaigns, and so for example in Scotland there's been the Zero Tolerance campaign, which sort of basically goes, we have no tolerance for any form of violence against women. That was quite powerful, as well as kind of broader UN campaigns of like Women Won't Wait, One Man Can, that are really trying to shift social norms about the acceptability of violence and to say that people can do something to impact on violence. What we did is design and evaluate an intervention that tried to tackle the issue of women's social and economic disempowerment. And we did this in rural South Africa, in Limpopo. And that was a partnership with a microfinance organisation. So that's a group that their core business is supporting small loan groups, taking loans, basically helping poor rural women access credit and support women to run small businesses. And the way they do that is to give out small loans with an interest rate. If the groups can pay back that interest, they can then access a larger loan. And so what we did is take that microfinance component. So this is a photo from one of the women who's got a small business. She's cooking food and selling it on the stall by at a market. And we added on a training package that we called Sisters for Life. And that was something that was really trying to think about how can we combine both an intervention that addresses women's economic dependence on their partners and sort of fundamental issues of poverty, but add on a component that is much more gender transformative and that tries to capitalise on the benefits that the economics might have. And so what we were trying to do is improve women's economic and the intervention was trying to improve women's economic well-being and financial independence, reduce their violence to HIV and gender-based violence, and also foster community mobilisation on issues that are of concern to women in that community. And this is a photo of women. This is a loan group meeting where there's someone doing the bookkeeping. They're counting the money that's coming in following the loan activities and sort of working out what they're going to do next. What we did in terms of the gender training, the Sisters for Life package that we added on, what we did is make that a compulsory element. So that was added on, and that happened before the main loan group meeting. Because women are motivated to come and try and make money. They aren't motivated to come and have a nice chat about gender and reflect on life. You know, they're too busy, there's too many other things going on. So it was kind of a forced intervention on them, if I put it bluntly, to start with. And then what we added basically is 10 one-hour sessions before this loan payment. And the kind of topics that we covered are things around gender and HIV, so sort of participatory activities to think about what are the gender norms in this community, how are boys socialised, how are girls socialised, talking about issues about domestic violence, about sexuality, about HIV, but also trying to develop skills in communication, in conflict resolution, in solidarity and in leadership. What we did then is to support an activity called Natural Leaders. So within each loan group, women who were showing some natural leadership abilities were given some additional training and were supported to work with their groups to develop action plans about what are the issues that they want to take to their community. Because we were trying to think about what's an intervention that can not only benefit the women in the microfinance in our intervention, but also potentially have ripple effects and have a diffusion effect to the community. And they received some additional training. In terms of the evaluation, we did a cluster randomized control trial. And so what we did is basically take 8 villages, and 4 villages got this combined intervention, and the other 4 were waitlisted, so they got that intervention at the end of our study. And the way the microfinance works is they map out the poorest women in the household, and then we did a survey at the start and at the end. And what we did is compare what are the levels of violence amongst the communities where the women who were receiving intervention in the intervention communities versus the control. And the way statistically that we do that is we average the figures over the number of villages, so in the end our statistical N is 8. So it's quite a limited statistical power. This was a study that we really had to beg, steal and borrow to fund. We had 6 donors. And so this was the sort of what we could fund. And so from the outset, we had very limited statistical power. But it was really to try and kind of say, can we work at this level? Versus talking about gender and economics being important, but actually never intervening at that level. So in terms of how the intervention went, there was very good intervention activity. A total of about $290,000 were actually dispersed through the microfinance, so pretty successful microfinance. Very high repayment rates, and the kind of things that women did, the stuff that women often do in those settings to make money, so it's buying second-hand clothes, washing them, ironing them, selling them on, selling food, running creches, these sorts of things. From the microfinance perspective, the company the business that was running that, their worry was that you add all this stuff on that's really sensitive, does that undermine our microfinance? You know, and if it does, that's a problem for us because they need those loan groups to function. So this plot here shows the percentage of centres that are vulnerable. So this is one of the metrics that the microfinance group uses. And this one is the groups that have image, and this is other villages where they haven't got that. So you can see actually the intervention was good for the microfinance per se, which was a big relief for us because, you know, that really, in terms of the microfinance audience, that was a very important data to be looking at. When we compared the intervention and control, even though we had very limited statistical power, what we showed is that over 2 years we more than halved the levels of domestic violence and physical and sexual partner violence. So we reduced it by 55%. We also saw that, and that was statistically significant even though we had a limited sample size, and that's because the effect was so big. We also saw that the households were less poor, and there was HIV communication. And then when we looked at young women, we had a higher uptake of VCT, of HIV testing, and also reductions in unprotected sex with casual partners. We did also look and say, did we see a diffusion effect to the broader community? And did we see impacts at the community level on HIV incidence? And we didn't see any effect there. But we saw very strong effects amongst the recipients of intervention. When we looked at, did that mobilization phase lead to anything? It was really exciting because there was tons of stuff happening. It was really frustrating because we couldn't quantify it. We really struggled kind of trying to capture everything that was going on. And you know, so there were, you know, this was the stuff we managed to kind of keep track of village meetings and meetings with leaders and marches. This is the local paper featuring some of the women who'd been out marching as part of the 16 days. And the kind of things that groups did weren't only about violence and HIV, it was things like alcohol, you know, selling alcohol to underage kids. It was about the police failing to take cases of rape seriously. There was a whole lot of activity that in the end women started to become engaged in, which for us was really exciting. The question that people asked us, they go, okay, look, you've got the money and you've got this gender training component. Isn't it really the money that is the key thing? And that gender training really didn't add much. So that's the question that comes back to us very often. So what we did in a subsequent analysis is say, well, let's compare the women who got the combination with women who got nothing, and then also with similar women who got just that microfinance, just the business component, just to see if we could tease this out. And this really messy slide tries to summarize what we saw, and I apologize for that. So when we look at, this one is our microfinance versus nothing, and this is our image versus nothing. So when we look at the economic indicators, we see that if you just give women the microfinance, it improves all the economic indicators. And if anything, it's probably a bit bigger in a few cases than when we have our combination. Okay. When we look at the empowerment indicators, it's much more messy. We don't really see any clear trend across these different indicators in terms of empowerment. So to me, that suggests that by giving women money alone, or engaging them in business activities alone, you can't assume that that's going to empower them in a sort of broader way. But when we look at image, we see a very consistent finding related to this. Similarly, when we look at levels of violence, we see kind of not very straightforward findings when we look at the money alone, whilst we see quite consistent findings across with our combined intervention, and similarly for HIV behaviours. So for us, it really speaks to that benefit of bringing together both the economic component and the participatory gender component into this intervention. So what we're doing now, because one of the reasons we were really interested in the microfinance model was because it gave us basically a cost-neutral backbone that we could build on. So the way that microfinance works is they continually scale up over time. They keep on taking their services to new populations. And so what we can do at relatively low cost is add that gender training onto that microfinance as they scale up. So when we first did the trial, we were in a few hundred households. By end of 2007, we got up to about 4,500, and by 2010, we're up to 15,000 households. And when we look at the unit costs, it started off when we were doing the trial, it cost us about $43 per woman to receive that gender training. But when we're sort of up to a few thousand households, we're at a cost of about $13 per woman. So it gives us a very low-cost way to try and deliver quite a sophisticated gender training program on a large scale at low cost. Okay. So I'm going to end that. I hope you've given a flavour of some of the work and thinking that's going on around partner violence and HIV. I think the sort of take-home messages are it's very prevalent globally. It's starting to be recognised as an important risk factor for poor health, and that includes things like HIV and poor mental health. There is emerging evidence that interventions can impact on the levels of violence, so it's an issue that actually we can be trying to think about what can we do in terms of prevention. I think our work with Image illustrates the potential synergies and benefits of bringing together some of the experience from development alongside sort of programming on gender and gender and sort of transformative norm change, and actually the power of bringing those two together. And for us, the sort of interest that we have at the moment is how do we try and feed some of that thinking into some of the sort of post-MGG 2015 discussions, which, if anything, are, I think, aiming for a more holistic and sort of joined up thinking about future development goals. But actually, in practice, you rarely see that in the field. So, but I think once you start looking at those combinations, they can be quite powerful.